Good afternoon. So I make it 1 minute past 2, and I think it looks like we've still got people joining, but we'll start anyway. We've done a number of these events now, and one of the big things is keeping to time. So we will work through it as quickly as we possibly can. Just a few points for housekeeping, just to everyone really to know. If you can, just keep your cameras and phone lines on mute. It just helps in terms of the bandwidth. So if everyone that isn't speaking keeps the cameras off and themselves muted, that's really helpful. We're going to use the chat function, which is the little speech bubble that should be in the middle of your screen. And so if you've got any questions, pop them in there. And if we can, we will either answer them during the course of this event, or if not, we will email out answers to everybody along with the slides from today. If for whatever reason your chat's not working, if you just use, you can see there, jenny.sears-brown@nhs.net. We'll pick it up from the email accounts, because we've just had a few instances in the past where that hasn't worked. But as I've said, you'll get all the slides along with the responses to all of your questions after the event. It'll be a couple of days from today. That's sort of the housekeeping. I just wanted to do a bit of an overarch, really, as I'm watching a lot of these names come up in the conversation side. Many of you I've had direct conversations or worked with as my role as the urgent care lead for the Midlands. And in that role and on behalf of the region, I just wanted to say a huge thank you. I think the last few months have been a trying time for many of us in the NHS, and none more so than a lot of you that have been serving on the front line. So just on behalf of the Midlands region, a huge thank you for all your efforts and hard work. I know we've got people joined us from outside of the Midlands region, and I'm really, really pleased to see that. I think it's a great opportunity to share learning. But I did just want to set some context for this for the Midlands itself. So for those of you that know us, we've been exceptionally challenged when it's coming to our ambulance performance, particularly around over 1 hour delays. And winter from us was a really torrid time in terms of seeing patients spending inexcusable amounts of time on the backs of ambulances outside our ED departments, and lost hour numbers that would make you want to weep in terms of the resource lost to our patients whilst we just couldn't get those ambulances offloaded. And I think there's an absolute commitment from all of us that the last thing we want to do post this incident is ever to return to the numbers of waits that we were seeing in winter 1920. And it's really part of this that this event's come out of, really, is how do we learn from some of the incredible things that have happened in recent months through the event. We get to a point where our patients don't have to have those huge waits getting themselves into the ED departments. So we've done a lot of these events, actually. We've been looking at frailty, we've been looking at ED front door, we've got one around operations. So this sits in a portfolio, really, of improvements and learning that will all help to come together to improve patient experience, outcomes and their journeys across the Midlands region. And I'm so excited looking at the lineup of speakers we've got for you today, national and regional representation, all coming together really to present how we learn from these lessons and take them through into the restoration stage. So I'm not going to witter on any longer, because I'm really pleased to announce Anthony Marsh is opening up for us today. Many of you will know Anthony both from West Midlands Ambulance, but also he's been our national lead throughout this incident as an ambulance perspective. So Anthony, I'll go on to mute and hand over to you. Thank you.
Okay, Charlotte, thanks very much. Hopefully you can hear me nice and clearly. Thumbs up, Charlotte, if you've gone now. Hopefully I'm sure you'll soon shout if you. Yep, all right, Charlotte. Yep, back on. Great, fantastic. Okay, well, listen, thanks very much for the introduction, and particularly a big thank you to all of you for joining today's event. It's great that the Midlands have taken the time and the effort to arrange the event, but also really important and grateful for all of you taking the time to join the event. It's a great opportunity, as Charlotte said, to update colleagues on where we are and to set out what I think the phase for the actions for each of the next few phases. I think the first thing to say, overwhelmingly, that the ambulance service right across the country has responded remarkably well to this global pandemic. It's put pressures on the NHS right across the country, including the ambulance service. But the extent to which the ambulance service has really embraced those pressures and stepped forward has ensured that we've not only firstly protected our staff, but also helped all of our patients and saved as many lives as possible. And so please accept my grateful thanks as the National Strategic Advisor for Ambulance Services for everything that colleagues in the ambulance service have done, but also everyone that supported the ambulance service take forward this essential work over the last few months. But of course, we're not out of the woods yet, are we? The next few months going forward are going to be even more important. So if I just spend a minute or so just reflecting on where we've come from, how we've responded, and more importantly, what we're going to do going forward. It seems like a long time ago, but you will all remember how difficult Q3 was. Winter arrived early with very high seasonal influenza, and that put an awful lot of pressure on the NHS right across the country. 4-hour performance was seriously challenged, as was ambulance service performance in most ambulance trusts. Not every hospital, not every ambulance service was under as much pressure, but there was serious pressure right across the country. As a consequence of that, we were asked to stand up the National Ambulance Coordination Centre. That stood up the back end of last year and helped coordinate the ambulance service response right through the winter. And not only helped through the winter, but also then helped with the very severe flooding. And again, that seems like an awful long time ago, but actually was only about 3 or 4 months ago. We had very serious flooding in many, many parts of the country. Some of that flooding was at record levels. And the ambulance service again responded fantastically and kept everyone safe right across our communities, many of whom were isolated for many days or even a few weeks. So we came out of all the flooding, we came out of what would have been a fairly normal winter other than Q3. The weather was pretty kind to us. We didn't have very much snow anywhere in the country, not really a lot of frost. And just when we thought perhaps we'd got through the winter, the global pandemic COVID-19 arrived in our country, and we started to see very, very substantial increases in emergency activity, and that included the ambulance service. I transmitted a very clear message to all the ambulance services that we needed to act now. That was the middle to the back end of March. We needed to take all reasonable steps now in order to firstly protect our staff, to be able to help all of our patients, and to save as many lives as possible. And every ambulance service responded to that call for action to ensure that we got ourselves onto the front foot, we got ourselves into a strong rhythm that meant we were able to manage that surge, support ambulance services through mutual aid where that was necessary in order to uphold the values of the NHS and the ambulance staff. But we didn't do it on our own. The ambulance service, very fortunate to be able to draw upon our colleagues from St John Ambulance, from other charitable organisations, and indeed from individuals that have been undertaking their academic studies at universities, undertaking their clinical placements in local ambulance services. And we mobilised many of those year 2 and year 3 student paramedic graduates onto the front line, working alongside qualified technicians and registered paramedics in order to maximise the number of emergency ambulances on the streets. But we also work closely with PTS providers, whether that was in-house NHS ambulance services or indeed third-party sector, to ensure that we could convey discharges, predominantly discharges out of hospitals very, very rapidly once those patients were booked ready for discharge, so that we could really maintain that flow, rapid flow through all of our acute hospitals, so that we didn't have the pressures within either the beds or within emergency departments. And the PTS again have done a fantastic job in discharging, but also creating additional emergency and urgent capacity by creating high dependency tiers, or whatever local ambulance services have called those, in order to strengthen them to maximise the frontline capacity. As we started to see that increase in emergency activity, we took the decision nationally to invoke the Protocol 36, which essentially is an additional filtering system on the front end of AMMPDS, the Advanced Medical Priority Dispatch System, and NHS Pathways, the 2 triage systems in place in all ambulance services to determine which category 999 patients should be placed after a series of questions. We implemented Protocol 36 in order to do essentially 2 things: ensure that patients had the most appropriate response to meet their need, and also by doing that, protecting ambulance assets so that if that surge continued to increase, there would be sufficient paramedics and sufficient ambulances to respond to category and 1 patients, and therefore provide enhanced clinical triage to even more category 3s, even more category 4s, even more category 5 patients where that's safe to do so. And we have arrangements in place to be able to escalate to surge level 2 or 3 if that becomes necessary. Thus far, it hasn't been necessary. We've only instigated level 1, and we've remained at level 1. So we're hoping that we won't need to escalate. In fact, we are undertaking a review currently to determine whether we should de-escalate and remove that initial protocol. That review is underway, and we'll make a decision on that in the next couple of weeks. At one point at the back end of March, a couple of ambulance services were under an awful lot of pressure with increased 999 calls, and their ability to be able to answer those 999 calls, having been connected by BT, was being undermined. And as a consequence of that, we took 2 actions. Firstly, we worked closely with BT to put a filtering system in place by which if callers only required information about COVID-19 and their potential symptoms, they were signposted to NHS 111 online to be able to get health information and advice online rather than tying up 999 lines. That helped us enormously, and we're now looking to stand that arrangement down, given that the number of callers that only require information, not a response or urgent clinical advice, is no longer required. The other step that we took was to ensure that we provided the technical link between each ambulance control room across England, such that if an ambulance service was under pressure and BT were having to transfer those calls elsewhere for those 999 calls to be answered initially, that if those calls were being answered by another 999 ambulance. Can you hear me now, Charlotte? Yeah.
Yeah, thank you. You've just come back.
Yeah. So that if BT weren't able to connect the 999 call with the local host ambulance service, they could connect that 999 call to any other ambulance service in the country. They could take all of the information and then pass that case electronically without the need to speak to the host ambulance control, so that they could then dispatch the appropriate help. And I'm pleased to say that now all ambulance services, bar one, can take calls for each other and pass them around the country, and that's a fantastic piece of work that we've now completed. So if I move on and say a little bit about testing, this is a really important aspect for our staff, to be able to protect our staff and their families, and to maximise the availability of frontline staff, so that we're not losing staff either through self-isolation, awaiting tests or waiting their results. The swab testing has now been in place for some time, and I think it's true to say that the ambulance service, the NHS, has really got ourselves into a strong rhythm in relation to swab testing for symptomatic and asymptomatic staff and their indexes. We're now moving into the next phase with the serology testing, and over the next 6 weeks, our ambition is that all NHS staff, all ambulance service staff will have had that test made available to them where they want it, and will have received the results. And I think that's an important part of our overarching strategy for the country in combating COVID-19. Underpinning the ambulance service response has first and foremost been protecting and supporting our staff. Protecting our staff by making sure they've got the right quantity of PPE. Yep, thanks. The right quantity and quality of PPE for ambulance service use, given the nature of the work that ambulance service staff are undertaking, often in a very uncontrolled working environment, working outside very often rather than in a controlled environment within primary care or within an acute hospital. And now, of course, supporting our staff, particularly staff from a BME background, it's more important that we do everything we can to protect them. So moving forward in my last minute, firstly, to ensure that we maximise the silver lining from COVID-19 and continue to reduce unnecessary conveyance where that's safe to do so, maintaining the substantial progress that's been made in relation to reducing handover delays, and that's something that we'll be taking forward nationally. We're going to stand up the national programme that restarts next week, and the extent to which the ambulance service can support the restoration of critical services as we move into phase 2 and phase 3 of the NHS. But of course, there's some unknowns. The easing of the lockdown, how will that play out in terms of public behaviour, businesses reopening, schools reopening? And then the final point is around the winter. This time of the year, we are preparing the NHS, the ambulance service is no different. In May, June, July, we're preparing for the winter. We look back to see what worked well last year and build those into plans going forward, and to strengthen those areas which were perhaps not as good in previous years that we would like them to be. This year is no different, but of course there's a couple of things. Firstly, will we have a vaccine tested, approved, mass produced and administered to the general population by the winter? I think that's probably highly unlikely, but we hope that that will happen. And secondly, of course, the 3 known risks that we always move into winter: the weather, seasonal influenza and norovirus, and of course this year the added complexity of COVID-19 and how will that play out over the winter. But the important point is that the NHS has really stood up well to dealing with the surge, to responding to COVID-19, and despite the high numbers of individuals that have sadly passed as a consequence of COVID-19, had we not have stood up to the extent to which we have, undoubtedly those numbers would sadly have been even higher. So Charlotte, I'm going to stop there. The final note is a really big thank you again to all of you and your colleagues for everything you have done and continue to do. Please pass on my thanks. I'm very happy to take any questions. Charlotte, please.
Thanks, Anthony. I think we've not got quite time for questions now, but if anybody has got anything, pop them in the chat. We will make sure that we speak to Anthony and get those responses to you. So I'm going to quickly move over to Mark Doherty, who's a member of Anthony's team in West Midlands Ambulance Service. Just a little bit of context for those of you from outside of the region. In terms of COVID, we saw quite a big variation between the West Midlands, which was much more greatly affected than over at the East Midlands. So Mark's going to take us very much through a journey of what we've seen during COVID from West Midlands ambulance response. And then we'll rapidly hand over to Will Legg, who's joined us from the East Midlands Ambulance Service, who's going to look more around the restoration and look forward post-COVID. So really great. We've got both of our teams presenting slightly different journeys for us. So Mark, I'll hand over to you. Thank you.
Right, thank you, Charlotte, and it's really nice to be part of this. What I'm going to do is I'm going to whiz through about 20 slides in 10 minutes. I'm really going to take you on a very quick journey. What I did to compile this presentation is I asked a lot of our senior staff that have lived and breathed this for the last few months about what they think went well and what they think could have been improved. So these are not my views, these are a collective view of probably about 15 of our very senior staff. So if I can have the next slide, please. So what went well? So we'll go through these. I think the first thing to say, as Anthony's mentioned, we went from one major incident, as in the flood, straight into the COVID global pandemic. What worked well is our structure, our strategic and tactical structure came together very, very well. I mean, I have to be honest, it's what ambulance services are good at. They do these things very well, the command and control and all of that. Very early on, we established a COVID strategic coordination cell, and that was a really critical thing for us to do because it gave us senior command of this pandemic. We very quickly repurposed the headquarters, so any non-essential staff that, sorry, I shouldn't say non-essential, staff that could work away from the headquarters were encouraged to do so. So what it meant is we had dedicated rooms for example, the COVID cell. And the other thing that worked really well was a very bold decision making and an early implementation of the COVID pandemic or the pandemic plan to deal with COVID. So if I can have the next slide, please. The COVID testing we implemented very, very early on. At one point, we had about 1,000 staff off isolating. And at that point, only about 2,000 tests had been done on NHS staff. Within a few days, we'd sourced some private capacity and also some of the early drive-through capacity. So we were very quickly able to get some of that testing capacity done. And the testing arrangements now are considered to be very slick, considering the challenges that ambulance services face by having staff spread across a large area. We managed to address that particular issue very well. And our recruitment was really, really good as well. We recruited lots of additional staff, something like 200 more call handlers. And we were able also to use this as a means to dual train staff that had come into the 111 service. And we were able to dual train quite a large number of those into being able to handle 999 calls as well. Sorry, if I can have the next slide, please. Communications was something, excuse me, that went both very well, but you'll also see this on our list of things that could have been improved. We set up some things that we hadn't done before. So, for example, we had digital signage via the TV screens in the control rooms buildings. And also we set up some for staff that weren't going to be working in a headquarters building and working remotely. We set up some daily conference calls to ensure that those staff were able to keep up to date with what was going on. The other thing that's gone really well is the introduction of Microsoft Teams. We've had this available to us for a long time. This is now business as usual, which I think has worked really, really well. So the next slide, please. Business continuity as well. We had business continuity plans that were enacted and also worked very, very well. The logistical support, this became a massive task by way of distributing stock in numbers that we've not necessarily had to deal with before. An example of that is in our PPE, where pretty much for most of this pandemic, we've managed to keep stock updated and replenished. We've not had significant shortages of PPE, certainly not from staff experience. We were able to rapidly increase our fleet. So just to give you an idea, on a normal day, we might put out between 350 to 400 ambulances. We were putting out over 500 ambulances, 520, I believe, at the peak. And the other thing we were able to rapidly do was expand one of our hubs. We happened to have available land that we were able to clear, level, and that effectively doubled our capacity at the Bromsgrove hub very, very quickly. The next slide, please. Yeah, so we'll go on to things where we think we could have done a little bit better. Generally, some staff say there was a bit of a blurring sometimes between what was strategic and operational, and sometimes the two blurred, and that did sometimes cause some conflict. There was certainly a high workload, and some people say that if we'd clarified roles a little bit better earlier on, the structure would have been more clear. The electronic logging, what was something that staff mentioned, and also some staff believed that we should have had more consultation early on. Of course, the downside to that is it takes longer, doesn't it, if you start involving more staff in decision making. But for example, our hazardous response team believed that they should have been more involved in some of the decision making early on. Next slide. One of the things that we would have done with hindsight is we would have got staff out of the headquarters building sooner. Staff that could homework, although we were quick to do that, we would have done that a lot quicker had we known how this pandemic was going to pan out. I think the other thing is that the organisational structure, what we need to bear in mind at times like this is that although the pandemic's going on and our response needs to be slick, nevertheless, the organisation still has to deliver its business as usual. And therefore, it's important that people are clear what their role is. We were actually fairly well instructed as to who was doing business as usual versus who was to be leading on the COVID response. And the other thing, of course, great with hindsight, but I think we would have engaged BAME staff much sooner had we known some of the issues that they they were going to be facing. Next, please. So the only other thing that we believe has come out through around the issue of communications was people have said we do a lot of this Microsoft Teams well, but actually what we may have done is reduce the amount to which we just talk to staff, and they would value more of that. Next, please. Okay. The business continuity is something we will always learn from. Most of that we got absolutely right, but there will be elements where we look at it and we refresh what we do. The logistical support was good. We did have some PPE issues, not by way of what we could get, but we have been criticised for not, on occasions, sharing some of our surplus stock. That's an issue that as soon as we were made aware of it, we did absolutely get onto that. We have, as far as I'm aware, not had significant fleet issues. We have had some staff saying that we had IT issues early on, where we've got wrap boxes that allow staff to access direct access to our network, and they were on occasion slowing being issued out. That wasn't my experience, by the way. My experience of our IT was that we got what we needed very, very quickly. Next slide, please. So general comments. I think innovation absolutely came to the fore during the early stages of this pandemic. We were wanting access to patient primary care records for some time. We've got massively improved access. It's been phenomenal. I think the remote working as well, people have welcomed that. And I think staff productivity has gone up as a result of that. People are able to communicate without having to travel long distances, and that's been very good. We've also used it as an opportunity to switch on some of our stuff. So the access to the video part of our electronic record in Birmingham is being piloted through what they call an Opal scheme, and that's been very good. We've had some really good pathway changes. So, for example, paediatric pathways in Birmingham, centralised on Birmingham Children's Hospital. We've enacted the stroke pathway in Burton-on-Trent. Those patients go to Derby. And we're also trialling a frailty pathway in Warwickshire, which is keeping more patients at home. And these are all things we may have done, but we certainly wouldn't have done them with the speed at which we've implemented them. Next slide. PPE has been a problem.
Can I just give you a 1 minute warning?
Yeah. PPE has been a problem. You can see the aprons on the left is what we got. The masks were disintegrating, and the aprons on the right, the dark blue one, is the ones we should have got. Next slide. We've issued a number of clinical notices. These are just examples. This worked really well. Next slide. And then the next slide. And I'll finish on this one, actually. Ambulance services have oodles of information. And what we found early on is we knew a lot more about COVID than many other people. So we published in the Lancet about 2 weeks ago. This was around patients with heart attack and stroke accessing the 999 emergency ambulance service. And the next slide. It just demonstrated that actually early on there was no evidence that patients were not contacting us with these tracer conditions. Next slide. This is the learning. Just prepare, prepare, and prepare, and you can't over prepare. Would be my view on these things. That's all, and I hope that was within 10 minutes. Thank you.
That's brilliant. Thank you so much, Mark. And I think, yeah, the preparedness is massive. And there are a few questions in the chat, if you wouldn't mind just popping over there, Mark, to drop some answers in. Thank you so much. I think that was really informative, particularly some fantastic reflections and some real honesty there in terms of what could have gone better. We were all in an incident that we never expected to be in, and the opportunity to learn from it was really apparent in your presentation. So thank you for that. And I think some of the pathway changes you've mentioned, we'll try and get copies of those and get them out to the distribution as well. So without further ado, I did give Will a little bit of an introduction before. Will's going to talk us through from an EMAS perspective now, looking at how they're moving towards restoration and how we move post-COVID, let's hope, over the coming months. So Will, if I hand over, thank you.
Thank you very much indeed, and good afternoon, everyone. Thank you for the exciting opportunity to come and talk to you about some of the work that we're underway with now. Been planning for a little while, underway with now, and over the next few weeks going to be starting to get some really interesting information out of. So can we go on to the first slide, please, after the title one? Next one again. Lovely. So what I wanted to do, I've just got a few slides which just kind of outline our approach to the restoration, recovery and reset work. I think, you know, the figures across the ambulance service in terms of things like handover delays, ambulance performance, you know, conveyance rates, all of the usual metrics that we would look at are in the public domain. And my presentation today is kind of the next bit of understanding on, if you like. So it's how we approach locking in some of those changes that we've seen, how we understand how some of those changes came about. And more importantly, hearing from our staff, and I'll talk a little bit more about that as I go through the presentation. So it's clear now, and we've all seen the national guidance in terms of the restoration, recovery and reset language. I think if you'd have asked me 3 or 4 weeks ago how I was going to term this piece of work, I think we all had our own individual versions of what restoration, recovery and reset looked like. I think I had renewal in mind somewhere. But we've aligned now in EMAS to the national way of discussing these matters, restoration, recovery and reset. And I think what's really interesting from our perspective in EMAS, looking at the national phasing of restoration, recovery and reset, and that's being asked of the ICSs and STPs, is that actually our timelines feel quite a bit shorter around these 3 areas. And that's certainly the conclusion we've come to, because the restoration and recovery work, when you think restoration predominantly is around looking at the Simon Stevens phase 2 letter, making sure that we can move back to delivering I suppose a more baseline service that we've been used to delivering before, and then considering implications of other services as well. So if we think about PTS for a second, you know, the PTS services across the country have been focused on discharge and supporting the most vulnerable patients, so renal oncology patients, for example. As outpatient starts to ramp back up again, there's some real choices to make in terms of how PTS services are kept being sustainable for the longer term. Social distancing means 1-to-1 patients on vehicles these days, rather than 1-to-5 or 1.5 ratio that we're running before. So ultimately, we've got some work in the recovery phase, which dovetails with some of the acute work and some of the more system level work, but it doesn't feel as though it's going to take a huge amount of time to get through that. I think what's really evident for us is, as I said, how we lock in some of those transformations that we put in place. Leon, in his presentation in a few minutes, is going to talk about some of those transformations specifically. But it's how we lock in some of the benefits that we've seen from having those transformations in place, and the kind of rapid process that we put them in. And to be able to understand the difference that they're making on the ground, how some of the output metrics are changing, we're going through what we've termed internally a discovery phase. And this discovery phase is effectively surveying our workforce. So we've got 4 surveys live in our organisation right now. They've been live for about 4 days. And they're covering our 999 frontline staff, our PTS staff, our EOC colleagues, and also our enabling staff. Just like West Midlands, we've had to move pretty much all of our corporate staff to work from home, and we did it really rapidly, and there was almost no chance for them to prepare in any sense for that kind of change on that scale. Our frontline staff, we know, have been managing fantastically well through this period. We're all ears and absolutely want to understand from them in their own voice and in their own feedback what those changes have meant for them on the front line, what they've experienced which has been good, what they want to keep, what they want to stop doing, and how they want to support the kind of long-term transformation in the organisation. All of that information coming back, which incidentally we've got just under 500 responses now to that in less than 4 days actually. All of that information coming back is going to feed into our reset phase, which actually, somebody pointed out to me the other day as I presented this slide somewhere else, the reset phase actually started minus 2 months ago. And that's because the rapid transformations that we put in place actually occurred before any of this 3R work started. So the transformation work and the kind of check over the strategic objectives for EMAS in the medium term is all going to come based on the feedback from staff and across all of those groups. Next slide, please. So we've set ourselves up a bit of governance internally just in terms of coordinating this restoration recovery work and then the discovery phases. So Mike, as our Deputy Chief Executive, is leading the restoration and recovery work specifically, and then I take over the discovery and the reset work in a few weeks' time. We've got various work streams which sit under our restoration and recovery phases, and as you'd imagine, they cover everything from estates, IM&T, kind of looking at ARP delivery, operational efficiencies. There's quite a big piece to consider around the finances of the organisation, the contracting side, future workforce planning, ensuring our procurement and logistics are able to cope with a new and evolved world as well. Next slide, please. So in terms of the discovery work, I've kind of outlined the core principles of it so far, but the operational and corporate staff survey side is only really one part of all of that discovered knowledge, as I call it, as we go through this process, because we're also undertaking a piece of work where I'm interviewing individual leaders in EMAS about the rapid transformation approach that we had, understanding what supported rapid transformation, and how, if there were any barriers before, how those have suddenly changed. Where has the risk tolerance changed? Understanding how the organisation has suddenly been able to move to a place where it's able to enact changes on a really quick basis. We're also going to couple that, of course, with the quantitative data, which was the data that I mentioned earlier, so the output data and also the clinical metrics. That's going to give us a really clear picture of the transformational changes which have happened, and then how those are affecting our outputs as an organisation, and then obviously we can embed that into practice. Can I go to the next slide, please? I don't know whether it's happened to anybody else, but the slides have disappeared off my screen for a moment.
We just lost the slides, I'm afraid.
That's all right. I can just talk through the last
no worries. I'm getting those back up now. A member of the delegate list enforced coming in and sharing their own screen. So if we could ask other people to be wary of what they're clicking on, and I'll restore it now.
Thank you. Don't touch, everyone. Thanks, Will.
No problem. Which slide are we going to get? Right, so next slide, please. Okay, so I'm not going to dwell on this slide, it's just our timelines, but the survey closed, all of that survey work closes in EMAS on the 12th of June. We can see how it's progressing as we go along and see the trends of information which are coming back. And I actually think through everything that I've seen so far from that work, that we're going to have some quite surprising results come back from some of that. Certainly one of the themes that is coming through loud and clear to us already is around through the COVID-19 process, the fact that clinicians have felt more supported clinically than they ever have before, and the I suppose reliance on their clinical judgment rather than being wrapped up in particular SOPs or predetermined processes has allowed them to flex their clinical muscles a little bit more than they have done before. So I think there's some really interesting learning for us as an organisation as we start to analyse that data, and certainly from a corporate staff perspective, again, some really interesting trends in terms of acceptance of home working, the use of technology, whether they feel that their roles are compatible with home working, etc., etc. Some really useful data which is coming back. The only other thing I was just going to mention on this slide is Facebook Live. So as part of our engagement strategy with our staff, as we started going into the main response to COVID, we decided we needed to try something new and different in terms of engaging with our workforce. And we're really conscious, over 3,500 employees spread across the whole of the East Midlands, really difficult to have a meaningful one-to-one conversation with them on a kind of board to frontline level very easily. And what we found was that the EMAS Colleagues Facebook group, which is not an EMAS corporate owned one, that was set up by colleagues for colleagues. We had a chat with the moderators of that Facebook Live group, and they allowed us to do a Facebook Live broadcast of 3 of our board members, socially distanced from Horizon Place, our HQ, to predominantly talk at the time. That first one was around PPE concerns, clinical questions, not around individual patients, obviously, but about presentation, those kind of things. And it gave Richard, our Chief Exec, an opportunity to thank and support the frontline crews as well.
Obviously, can I just give you a 1-minute warning? We're just getting a bit tight.
No problem, thank you. And that, for anyone who hasn't used Facebook Live, it's an interactive platform where it transmits the video out to everyone who's logged on at that point in time, and then people can pose questions which the panel can answer, etc., etc. We've done 4 of these now. The next one's next week. We change up the panel members. It's fantastically well received. Generally speaking, we get anywhere between 200 to 250 people watch it live at that moment in time. And then after that, anything up to about 2,000 views for each particular broadcast that we do. And it feels like it's a new integral way for us to communicate with staff. Just the last slide, please, if you can. Could I just go to the last slide, the one with the 6 boxes on? Lovely, thank you. And this really is the why, and I'm happy to leave that on the screen. I don't need to walk through it. I'm sure we're all asking the same kind of questions, but this is kind of some of the core underlying reasons why we're doing this work. Happy to finish there, and any questions, please pop them in the chat box, and more than happy to answer them.
Thank you, Will. Yes, you've got some questions in the chat. That was really informative, and I think a lovely theme through both yourselves and West Mids is this engagement and work with staff, something we've always been a bit guilty of maybe in the NHS not doing well, so it's fantastic to hear how that's flowing through, so thank you for that. I'm going to quickly move on to Keith, who's joined us from the National Ambulance Coordination Centre. So for those of you that aren't aware, they've held us through the winter, keeping an overview and oversight of all of the ambulance services nationally, and will continue to be stood up throughout the COVID incident. So Keith kindly agreed to come and talk to us about some of the work that's been happening there. So I'll be quiet now and hand over. Thanks, Keith.
Thanks, Charlotte. It's a real pleasure to be invited here to speak today. So thank you. I'm the director of the National Ambulance Resilience Unit. One of our core functions in the Resilience Unit is operating, managing the National Ambulance Coordination Centre. Can I just move on to the next slide, please? Thank you. So originally the NAC was conceived to ensure that mutual aid across ambulance trusts in the event of a major incident, terrorist incident, rail crash, aircraft crash type thing, was so that mutual aid was able to be managed across the board, and trusts had a central point to come to. It moved forward with the incidents in Salisbury a couple of years ago, and then this winter the decision was made to set it up to manage the winter pressures. So it was stood up in November, and it was to manage the National Pressures Live dashboard. Now on that has got activity escalation pressures, number of vehicles on duty, hospital pressures, and it was set up to originally manage that, and it's set up with half-hour updates coming through, and various people had access to that to be able to support the whole system across the NHS across England. Moving forward, as we moved into COVID, it was really important that we were able to support the National Ambulance lead in some of his decision making. And so we added to the NAC with a National Ambulance Daily Sit Rep, the continuous national monitoring of specialist ambulance assets, so heart assets, mass casualty vehicles, and other national assets, and the collation and dissemination of information, guidance, and directions. So information coming in to assist the National Ambulance Advisor, and information going out and decisions going out. And we can move on to the next slide, please. So some of the mechanisms that were set up right at the beginning of the COVID where strategic oversight and new national guidance was introduced. We produced in NARU, we produced various documents to support the national capabilities, and that included new guidance around more longer term mutual aid, the way that the NAC actually operated, because it was, as I said, it was set up really for those big bang incidents, and it was important that we were able to respond to this longer term issue, and we rapidly enhanced our on call provision across the board, both at a national level with Anthony and at a NAC level. We put new processes in place to ensure that all decisions around military aid for the civil authority came through the NAC and were acted upon by Anthony himself. And we put various new processes in place to ensure. One of the areas we were really concerned about at the beginning was how staff sickness could potentially affect our ability to respond to a terrorist incident. And we put new processes in place to ensure that we maximised our staff and our heart staff and our supporting staff who were able to respond to those type of incidents. One of the main areas was to ensure that strategic consistency right across the board, because there were many new initiatives coming through, new areas of thought, and it was important that Anthony was able to keep a grip of those and manage those new initiatives that were coming through and decide which ones needed to be introduced across the country. So it was really important that those were brought to the fore. We can move on, please. So as I said, Anthony touched on this during his opening remarks around the actions that he needed to do. Much of it, as I've said, is managing that mutual aid, whether that's local county mutual aid, so asking for support from the neighbouring ambulance service, managing any potential national mutual aid that would come from all parts of the country to support a trust, and of course that national contingency mutual aid from the St John's ambulance and voluntary organisations. Anthony's role was to oversee all ambulance service planning and operations nationally, and I've said before, it was really important that he had all that information to hand to be able to make those decisions. Go forward, please, on to next slide. One of the things that was really important was to ensure that the staff in the NAC were supported. It's a small room, and Mark's alluded to the fact that we cleared space within the West Midlands headquarters where the NAC is hosted.
Can I speak 1 minute? Sorry.
Yeah. So it was really important that we supported the staff in there and ensured that they felt adequately safe as well. We can just move forward then on to challenges. Some of the real challenges that we had were centred around culture. You know, the sharing of information right from the beginning. What's going to be used? What's that information going to be used for? Will our organisation look bad in comparison to other organisations? Processes, so the times that the information was needed, the sign off, who's signing off that information that's coming through to the NAC, or indeed we don't have that information to hand, we don't gather that information. Some of the technological issues with the trust dashboards, which didn't provide the information that's required, and then the data itself, around the interpretation of the data, what actually is the question that's being asked and its use. But what I want to do is mention the positives, because I could scrub out challenges there and put positives, because the culture, there's a can-do attitude in the ambulance service, and it really shone through. We managed to get this information very, very quickly. It was all sorted out. With any areas where we didn't have that information, it came through eventually. There were some innovative solutions came through, such as technological solutions. We thought we'd just be able to handball the information into spreadsheets, and we got it through technical uses as well. So it was really, really good. That I'm just moving forward again. Thank you. Just going forward. At the moment, the NAC is scheduled to close at the end of July. But we are going to support trust until that point, maintaining the new normal and that meeting the challenge as we move forward through the pandemic. And just on the last slide, just want to leave you with a couple of questions really. On the whole, the NAC has been very successful. It's not been without its problems. Lots of supportive mechanisms in place to support the NHS going forward. But I think there is a question in terms of gathering and providing information. Do we need to do that on a more consistent basis across the ambulance service, so that when we face problems such as this again, we've got that consistency of information right from the very beginning. Thank you.
That's great. Thanks, Heath. Yes, and I think the information is so important. Really interesting to listen to, while we were all so focused on COVID, all of the other things that were being taken into account around the ambulance resilience. So thank you. That national overview was fabulous. So we're going to go back over to East Midlands Ambulance Service. I'm very excited to be able to introduce Dr. Leon Roberts, who's the medical director from over there. He's going to talk to us about hopefully eradicating some of our long, lengthy waits to get our patients into our hospitals, and look at how we eradicate those delays going forward. So over to you, Leon. Thank you.
Yeah, thank you very much indeed. Slide, please. My name's Leon. I'm the Executive Medical Director at East Midlands Ambulance Service. I think the first thing to say is I'm completely inspired by sort of our staff, but also some of the possibilities from this COVID incident and the way that relationships and things are maturing in the sort of immediate care sector. So I hope that comes across in the next 8 or 9 minutes. Slide, please. It really does tie in post-COVID with the EMAS vision that was laid out 18 months ago of responding, developing, and the key thing here is collaborating. Slide, please. As you can see, EMAS most certainly going through into 2019 through 2022 were wishing to respond to our patients in the most appropriate way, developing how we become outstanding for our patients and, more importantly, and as importantly, our staff, and using any opportunity to collaborate with partners. And if there's one thing that I've spent a lot of time doing in the last 3 months, it's collaborating with key individuals who can unlock some of the potential on behalf of patients. Slide, please. We want to talk about patient and handover delays at hospital. And handover delays at hospital mean patients in ambulances, it means ambulances not on the road, and it means ambulances not responding to patients, and that means prolonged waits. And I wanted to just share a case with you, if that's okay. And this is not unusual across ambulance services in the UK. A call came in from police regarding a patient that was in and out of consciousness. Upon triaging, it became a Category 2 call. Sadly, our trust were unable to immediately respond to that Category 2 response, and it was some 2 hours or more until we got on scene. We didn't know and weren't updated that the police had actually left that patient in the care of a friend, and when our crew got there, this patient sadly was unconscious, deeply incontinent. We received no second call for this patient, and upon transporting to hospital, the patient was very sadly declared deceased. Slide, please. Only part of the explanation to that is ambulance handover delay and delayed response. And the slide really towards the bottom really sums this up. We'd wish to hand over our patients in 15 minutes at hospitals as per the national standard. And between midnight and 3 a.m., we had over 17 crews at the local hospital already waiting over 45 minutes to hand over. And prior to receiving that call from the police for this patient, we'd already got 16 crews that had been waiting over 45 minutes to hand over. A total loss of 21 hours of operational time while we've got patients sat on the stack waiting for a response. Overall, during the time of this incident, there was 45 hours lost to responding. Slide, please. Now, I know most people are going to be on the call or be aware of prolonged waits and poor patient experience due to these type of cases, but this is what happened in May. This is what national response, national strategy, CARD 36 responses can provide. And this is EMASA's response data in May this year for the whole month, meeting every national standard. We do not want to go back to where we were before, and that's why we really want to engage with this meeting to take things forward. Slide, please. A graphic of handover trends. You can see April 16 to the left, losing 4,500 operational hours in a month. You can follow that through to December 2019, where EMAS lost over 13,000 operational ambulance hours, hundreds of days lost sat at hospitals with patients on our vehicles waiting for handover. And I hope quite startlingly, you can see the April, and I've asked for May's data from 4 days ago. You can see our hospital handover delays in the last 2 months, since we've all worked collaboratively in a different way. It is as stark as you might need. A slide, please. Again, another representation of pre-handover delays for ambulance staff and decrease in nature. This is week by week from December 19 through to more recently, and I think the 3rd of May shows where we can get to. Slide, please. So what have EMAS been doing? I think if it's as simple as seeing and conveying less people, let's be honest, the ambulance sector would have done it before I became medical director 12 months ago. It isn't as easy as just taking less people to hospital. As Anthony said at the beginning, it's about choosing the right patients and being able to convey less in a safe manner. We genuinely believe in the right care in the best place, and that's going to involve engagement with our ED colleagues. Engagement, like prepare. But EMAS have found visible leadership really important during the last few months, and extremely supportive culture, particularly when we think about some of our inexperienced staff, we've got at EMAS, particularly with our NQPs and some of our new technicians that have recently bolstered our workforce. We have seen engaging with our staff has been absolutely key to supporting them in making more bold decisions on patients' behalf in a shared decision-making model. Slide, please. So what have we been up to? I know that Mark mentioned about GP Connect. Over 30% of our consultations now with frontline paramedics and technicians at patients' homes were accessing GP records. Thank goodness for GP Connect and that sequin late last year. We've set up a clinical coordination and support desk in our control room. We managed within a couple of days to get a job advert out for senior doctors with pre-hospital, GP and emergency medicine experience to run a 12-hour rota 10 till 10 in our control room for direct access for any crew member and a member of the CAT team in the control room to provide senior support. We've had a huge endorsement from our staff, both anecdotally, but also in compliments and direct emails to the clinical and operational directorate as to how effective that desk has been in the last 6 weeks. We've also made sure that doctor on the clinical coordination support desk has got full access to GP records, video consultations. We've got paramedics asking for the doctor in the control room to virtually join them on scene to see the patient and assist them in joint decision making. CARD 36 and the handling of calls has most certainly improved our category 2 proportion of calls and most certainly allowed for some of that timeliness of response that we have seen that I showed on that slide. Remote working, not losing our experience, our more senior CAT team members that perhaps would have been socially isolated or have been off ill, working from home, getting them triaging calls and hearing and treating remotely, not losing them to attrition. Direct lines to ED seniors at QMC and at Kingsmill allowed us direct lines, particularly with nursing home and care home patients, in order to discuss the relevance and clinical outcomes for patients being taken to ED. But mainly decreased handover delays, meaning decreased prolonged rates, which means timely care, which means good patient experience. And at the bottom there, supporting our Band 5 staff in that decision. Slide, please. We have reinvigorated a project from last year looking at Band 7 specialist practice. We'd identified a need to modify our clinical operating model to get some Band 7 advanced clinical decision makers and trained personnel, particularly on some of our Category 3, hopefully safe discharge at scene and pathway assigned cases. But we saw key to that having a specialist practitioner in the control room to dispatch those advanced practitioners. That was paused in March when we had 500 abstracted staff and in the face of COVID, but there's a real drive from our board and executive to reinvigorate that. We've been working closely with regional staff to utilise community emergency medicine services and PRU cars, working collaboratively and proactively with EMAS to select appropriate cases for face-to-face consultation by experienced clinical seniors. We acknowledge
apologies, I just give you a 1 minute warning.
Yeah, I've got 55 seconds. Acknowledging our staff anxieties and difficulties. Will's mentioned it. Executive Facebook Live, contacting thousands of staff virtually, answering their questions, been open and transparent, has made a huge difference to us. And our CAT team in the control room are no longer doing many welfare checks on prolonged waits. They're actually doing what we want them to do, which is hearing and treating our patients. Slide, please. So EMAS are passionate about the next steps. We're setting up a local pathways group to look at all the opportunities with particularly same-day emergency care and some of the access to clinics which may be relevant. And the relationship between us and some of our primary care colleagues is at an all-time high. It's brilliant to be having weekly meetings with our LMC chairs and hearing about positive interactions and adult conversations from professional EMAS staff with our GP colleagues. Primary care have been brilliant at sorting out respect forms, treatment escalation plans and personalised care planning, and they're talking about death, and it's making a huge difference for our patients when we get on scene when they've deteriorated. Slide, please. We want us to keep this. We don't want to go back to where we were. We want that handover delay slide to be a thing of the past. Slide, please. That's it from me. I think that's 10 minutes, 20 seconds. I'm absolutely delighted to be working with EMAS. We've got a really strong executive and engagement with our staff, and we just can't wait to take this forward in the Midlands.
Thank you. I can't follow that. That was inspirational, and it's made me feel all warm inside that actually we've got some hope and some real change coming to help things for our patients going forward. So that was brilliant. Thanks, Leon. I'm now going to move over to St John's. So the voluntary sector have been a massive player in the recent incident, and a huge thank you to all of them, and we're really privileged to have St John's here to talk to us today. So Peter and Adam are going to present some of the things that they've been doing and their fantastic work nationally around helping with our UEC COVID response. So Peter and Adam, I'll have to be tight on time, I'm sorry, but over to you.
Thanks for that, and good afternoon everybody. So I'm Adam, I'm the head of community response at St John. Over the winter pressure period, we stepped up our operation to provide a whole range of support to the NHS through NHS England, albeit ambulance provision predominantly, but also testing a hospital volunteering model where we put trained volunteers into emergency departments. I remember saying to my team, come the end of March, when winter finishes, we'll have a bit of a break, but apart from wanting to lynch me now, one good thing that has come out of this is our opportunity to bring hospital volunteering to the forefront. And in terms of capacity, we've been able to redeploy our event volunteers into this opportunity. The NHS long-term plan has a firm commitment of volunteering and a very professional volunteering model, which we aim to strive for. Next slide, please. So in the process with engaging with trusts, we to the end of May, we've delivered just under 45,000 hours of patient-facing care within a range of hospital settings across the country. We've worked in 23 trusts across over 40 sites. And specifically, we supported the Nightingale Hospital in London by providing 8,300 hours of patient-facing support in that department of a whole range of tasks, whether that be taking patients to observations, moving patients within the department, supporting patients ready to be discharged, and other tasks within an agreed scope of practice. Next slide, please. So in the governance and agreement, all of our event first aid volunteers are already trained to quite a high standard and regularly reviewed and monitored, received an additional 2 days of extra training to enable them to work within a hospital environment. We have an initial conversation with individual trusts about how we can support within the department, agree the scope of practice and the partnership arrangements. Most trusts already have a volunteering team that we were able to work with. We then move into signing an MOU and a service agreement, which looks at aspects of our recruitment, training, incident reporting, escalation, and then we hand the hospital opportunity over to one of our local operational contacts that gets our volunteers inducted and ready to operationalise on the ground. Next slide, please. So I'm going to hand over to Peter now, who's one of our senior volunteers, but also is an ACP in his day job, who is one of our operational leads who made this happen in a couple of our trusts. So Peter, over to you.
Hello and thank you, Adam. So just to explain the context, I work as an emergency department advanced clinical practitioner. I've helped embed volunteering within my own organisation, which is Lewisham and Greenwich, and obviously work as a senior volunteer within St John Ambulance. So after lots of work, we've developed a really good and robust clinical scope of practice. And what that has involved is our volunteers upskilling, receiving additional training, familiarisation, and refreshing the core clinical skills that they would already have to make them safe and prepared for working in our hospitals and emergency department settings. When we first started engaging with NHS trusts, this was obviously a real dynamic process that was occurring due to the nature of responding to COVID. And what we did do is we used our event planning experience as an organisation and spearheaded and developed the conversations with trust and sort of led those conversations. We're very much used to going into a situation when we're delivering events with event organisers, using that experience and that knowledge and the frameworks we have within event volunteering, and we brought that into the NHS, which meant we could rapidly deploy our volunteers. An example of where and how quickly we got volunteers into the organisation was training them on day 1 and day 2, which was Monday and Tuesday, and by Wednesday morning we deployed volunteers into an emergency department. Next slide, please. So as with anything, there are always positive and there's always challenges, but it's about us overcoming them together as partners. So some of the positives is we've been really, really well received across hospitals, across the country. We've embedded really well into the teams locally. We've been well received, and staff feedback from staff on the ground to executive levels has been really, really positive. Our volunteers have loved doing this and have really enjoyed the opportunity to consolidate some of the skills that they have through working at events and the new skills that they learn in their COVID-19 care training. What was really interesting is that an A&E department is like an event, except we don't always have the fancy equipment and machine because we're working on the roadside. Yesterday in the emergency department, we had some volunteers looking after a variety of different patients, all clinical complex cases, but it was just like being at Notting Hill Carnival, except we were in a building. Our volunteers are growing in confidence, they're developing. We've got to the situation where one of our volunteers volunteering in an emergency department is now been successful and has got a substantive healthcare assistant post due to the fact that they've done St John Ambulance for a prolonged period of time. They've had exposure in an emergency department. We've got a doctor who is trained in Croatia, who is originally from the UK, who has been accepted for a job to start in August. So again, we're basically again, we're future-proof in the NHS. Challenges is the turnaround for trust inductions and equally deploying rapidly our volunteers in the trust. But we've overcome that by working together. Next slide, please. A little bit about how our volunteers have brought something to the NHS. One of our volunteers was doing some time working with our streaming, which is the front door access of the NHS. And what those volunteers have done, and an individual, is come up with a concept of how best to sell and utilise and work together, and come up with basically a role description for that volunteer, which was signed off by senior clinicians and managers within our NHS. Next slide, please. Taking it back to the patient, a couple of case stories for UK studies. We had some volunteers that supported a patient with Down syndrome. The patient was unable to have a relative with them due to lockdown. And what our volunteers did is they built up the rapport. They were the first contact within the hospital that that patient had. And immediately they were able to reassure that patient, put that patient at ease, and link in with the patient's family remotely. Next slide, please. As you can see, a number of tweets. Our volunteers are really proud to be volunteering. Our NHS trusts, such as Hillingdon, are very pleased to have us there. We're already thinking about how we can work together to support the NHS in winter and make sure that this is a long-term vision and partnership with the NHS. Next slide, please. We've been really well received. We want reward and recognition to be at the forefront. Many of our volunteers working at the Lewisham and Greenwich site have been recognised for their leadership, their clinical care, how they've dealt with various difficult situations, and received positive reporting awards, which is a process where we recognise good standards of care. Our chief nurses at Lewisham and Greenwich have been at the forefront of personally writing to all the volunteers. We've got 80 volunteers volunteering at Lewisham and Greenwich, and they've been really well received. Next slide, please. So hopefully I'm roughly on time, a bit quick, but in summary, the next steps is this is a new form of workforce opportunity for us in the NHS. It's about us establishing the partnerships if they do not exist already. We want to be part of the NHS. We want to work with you. We want to consider longer term volunteering opportunities, and we will obviously develop our scope in partnership to meet the local service need. So thank you.
Thank you. So we rushed you a bit, Peter. So that's been really helpful. I've just dropped in the chat. If anyone's got any examples of voluntary service, please let us know, because it's a huge opportunity to engage them more with our working, and an absolutely fantastic group of individuals they are. So thank you both for that.
Thank you for letting us share our story.
To Jim Davidson, who's our regional clinical lead for emergency care, looking very dapper there or not in all of his masks. Jim has already completed one of these events for us across the front door with ED clinicians, so he's going to give us an overview of the work that's happening there, and the wider stakeholder piece around improving urgent emergency care. So thanks, Jim.
No problem at all. Thank you, Charlotte. Good afternoon, everyone. Thank you very much for hosting me here. This is a delight to be here. We've done one of these events for the emergency department teams, and really what I want to try and do is give you some feedback from that side of the that side of the handover process, so that you can get a feel for sort of the work that they've been looking at, and we use that very much as a starting point of reflection. So reflection on what we've learned, what we'd found difficult, what we'd found straightforward, what we wanted to keep and what we wanted to lose on our journey through this sort of restoration period. Chris, next slide, please. So an event very similar to this one, we had a number of sites feedback, and the next slide shows that was a really well attended event. I'm really disappointed to see that you've managed to get more attendees at your event than we had at ours, so congratulations, you have won on that front. I realise it's not a competition, but I do feel slightly bruised by that. So next slide. One of the things we found really interesting about the Midlands as a patch was the sort of the heterogeneity of how COVID had affected us. The variation between our big sites, our small sites, those very rural sites that are perhaps more distant from many of the other support functions that might wrap around the big metropolis. But also how actually the case quantities were so wildly different within the populations across our region. And that was interesting because it meant the experiences were quite different, and therefore the learning was quite different. And then Chris, next slide, please. And although we were moving into a period of improvement, and certainly that surge and peak that we'd seen towards the end of April was starting to fade away, it was important for us to recognise that as a region, we'd taken a big burden of the COVID disease and the challenges relating to that on the national stage. So although London had undoubtedly had the greatest volume and certainly had that very early experience, we were coming in closely behind those, and I think we had a lot to say and a lot to learn and a lot to share with others. So we were delighted that lots of people attended that event. So next slide, please, Chris. So I've brought together really 3 aspects of learning, and these are sort of loosely weighted. So actually the order in which they appear on this list is how often and how positively or negatively these were reported back by the different sites that were involved with giving this. And overwhelmingly, the top bits of positive, we want to keep this type of feedback from the ED leads and their teams were around the speed and implementation of system change, how barriers to change broke down very rapidly. Systems worked together very effectively to allow rapid change and rapid improvement of systems, certainly over those first weeks, while new ways of working were embedded and people got used to a new way of dealing with an increasing COVID workload, but also then a change in how that was attending our departments and when it was attending our departments. I think we all recognise that good flow through an ED pretty much equated to good ED care. None of the sites in the region had seen flow through their departments like we've seen in the last few months. In fact, you have to go back a very long period of time. You have to go back to sort of 2008 pretty much to see movement through departments in the way that we're just about seeing it now, certainly in terms of volumes of attendances. So seeing really good flow through EDs meant that patients moved out in a timely way. It also meant that patients could move in a timely way, and that was of course reflected in ambulance turnaround times. Communication was really positive. A lot of this probably comes about because a lot of the communication became single item. The noise that surrounds communication within a hospital system or in a wider health economy became very focused, and because of that, communication became excellent. People could share information rapidly, could share thoughts rapidly, and that worked really effectively. Almost everyone's estates did brilliant work in terms of separating departments, putting up temporary barriers, putting up new systems, creating new spaces for patients to be seen in. And the movement of minor injury working has generally been perceived positively across all of our sites. I know that there's been on some local sites some complexity around people knowing where minor injuries are being treated and being looked after, but in the main part this has responded really, really well. The move of senior decision makers in EDs either to the back of ambulances as people arrive, or to receiving ambulances, or to very early inpatient pathways has inevitably helped move patients through a healthcare system well. And lots of sites commented that the step up in mental health provision has been a real positive in terms of either moving patients who could do out of the ED setting and into a mental health setting, or speeding the rate at which mental health services were coming and interacting with patients. Chris, next slide, please. One of the things that I think we've reflected on, and I know that we've discussed earlier on, was around how activity presented itself to EDs, and a lot of concern in those early days about high acuity diagnoses not attending EDs. It does look, with hindsight, that actually those volumes were relatively small. And better analysis of the workload that is now attending EDs and being brought to EDs because of all of the work that ambulance services have done around conveyancing has meant that the low acuity, those that would be discharged without diagnosis, without intervention, are still not returning at the rates that we thought that they might, whereas those high acuity patients are coming back into our services. Next slide, please, Chris. So the negative stuff, what would we get rid of? What did EDs find unhelpful and not positive? Well, the flow out of departments was sometimes limited by the ability to process testing, to avoid batch testing, and hospital management systems around ward cohorting, side room cohorting, or holding patients in an ED setting until test results were back. a number of the smaller sites struggled enormously with dividing their ED footprints. The real estate of a lot of our hospitals is old and would not be considered fit for purpose in a modern ED design programme. But it is the ED footprints that we've got, and some of those did not take well to division into red and green type zones for COVID and non-COVID workload. One of the disadvantages of having a real estate that isn't predominantly based on four wheels is that it's relatively hard to update it. And so some sites have done very well and some sites have found that much more difficult. And then the two final bits are concerns around actually the fallout from the post-COVID period and this desire certainly from acute trusts to push to old practice and old ways of working. There are a number of challenges for acute trusts in terms of income generation and elective pathway process, which of course puts pressure back onto the urgent cares pathway, and a lot of concern from the ED community that we can't return to the old normal. We have to maintain a new system of working and a new system of delivering healthcare. And for some sites, the pathways have become incredibly complicated. Certainly, ambulance services would have seen this on attendance to hospitals, because you'll have found that patients are being brought into hospitals in many different ways, through many different doors to many different units. And keeping track of some of these ways of dealing with the pathway complexity has been complicated. Each of those individual services wants to return to a more normal level of practice. And so detangling of the new pathways that were put in place has been somewhat, or is being somewhat more complicated. Next slide, please, Chris. This was a bit
tight for time. Sorry.
No worries. I'm belting as quick as I can. I'll be speedy. I bring this up really just to highlight there's many ways that you can look at work that you've undertaken during a COVID response or a sort of a crisis response period. Interestingly, a lot of the negatives that were flagged by the ED community don't fit into any of these boxes. Actually, there are things that we didn't stand up well. So it wasn't new things that we put on, and it wasn't things that we used to do that we should just get rid of. It's stuff that we tried to change, but we didn't change brilliantly for a variety of reasons. And I think there'll be hard things to untangle. Next slide, please, Chris. So what did EDs want help with? Well, they wanted help with how do we provide a focused change for improvement and not return to old practice? How do we maintain safety for staff and for patients in the post-surge COVID period? But while this continues to be a disease that is likely to be with us for the foreseeable future, particularly for protecting shielded patients and the more high-risk patients as they come into healthcare settings. How do we maintain some of those alternative pathways that really work? And then how do EDs work even more collaboratively with the 911 services to really bring a system together? Now, next slide. This really helps in that this fits in with some of the messaging from the Royal College of Emergency Medicine about not allowing EDs to become crowded again, and looking after staff and looking after patients as they come through those departments. Next slide, Chris. Thank you. And then this fits, I think, very nicely into the thinking around how 111 may become a very, very useful clinical signposter to a variety of new ways of delivering services that may include heralded or sort of booked ED attendances, or certainly more scheduled ED attendances, but also access into those pathways that have been stood up over this COVID response and should be maintained, so that not every answer is either one of dispatch an ambulance or send to hospital. It may be sent to hospital, but it may be sent to hospital through a different route. Final slide, please, Chris. So within EDs, the shielding of patients will need to be well protected to allow patients to be cared for safely, and certainly a form of alert service through the ambulance service, I think, will be needed to do that. And EDs will have to get used to the idea of heralded and unheralded patients, so that they can deal with workload in a slightly different way and maintain a social distancing approach. And then it is the final slide this time, Chris, and then I'll leave just on this, which is, these pictures are well known to us, but I think some of the feedback from the ED world is that this probably does need an additional line and that the ideas that there were only these ways into the NHS service probably won't be ones that continue. But the idea that one can access a hospital service through either ambulatory, same-day emergency care, same-day frailty care, or directly to specialties will find its way into this, access through 111, 999, or through streaming once patients do attend an emergency department, so that patients are embedded into the right place. So that was a whistle stop. Hopefully we've caught us a little bit of time. Chris follows me, and he's also an excellent speaker, so hopefully he's got enough time to wow us all with data.
Thanks, Jim. You've got a few questions in the chat, so if you could go there, that'd be brilliant. Chris Green, I'm not going to take any of his time other to say that he is fantastic. He's the ECIST king of all things data and analytics, and he's going to take you on a whistle-stop tour, which I know you're all going to enjoy. So over to you. Thanks, Chris.
Thanks, Charlotte. I hope everyone can hear me. I need to take Charlotte and Jim with me everywhere I go so that they can introduce me. So thanks very much. My name is Chris Green. I'm the Head of Information for the Emergency Care Improvement Support Team at NHSE. I'm going to give you a bit of a whistle-stop tour, hopefully. So I've got about 5 minutes, and I'm really going to talk to you about data and how we can kind of turn that into a bit more intelligence and then leading on to action. Or as I phrased it, what have we seen and what does it mean? Chris, can we go on to the next slide, please? So in terms of NHS data, it really is unprecedented times. You know, the stuff that I do pales into comparison to what people do on the front line do, and it's been fantastic to hear, particularly from people like St John's Ambulance and the ambulance services around what they're doing. But NHS data has never seen such variation. And we're going to be looking at that through some of the slides that I've got. This is looking at national data, but I've also got it for the Midlands and the East regions, which I'll come on to talk about in a minute. I think the important thing to realise, though, is this doesn't just happen. It happens through a series of events, and the COVID pandemic has caused a lot of people to work in a variety of different ways, innovative ways, very, very new ways, and it'd be interesting to see how that one pans out. We've seen significant reductions in attendances. There has been a significant variation, though, in the reduction in walk-in compared to ambulance patients, and we'll come on to that. There's also been significant reduction in occupied bed days, and as many of the ambulance providers were talking about, a reduction in handovers. But we're also going to think about how this impacts on flow through the rest of the health economy. And I think that's a really big key message to take away from this, is actually how we're going to kind of take this one forward from a whole system view. If you go on to the next slide, please, Chris. So this is what I call my starter for 10. This is the ECIST UEC dashboard, which comes out every day. It goes to about 3,000 people. And what this really tries to identify is things that are statistically significant. Okay, so data goes up, data goes down, like house prices, like petrol prices, like anything. But what we really want to be able to identify is things that are statistically significant and what we should pay attention to. We go on to the next slide, please, Chris. So when I said about the reduction that we've seen in attendances, so a very, very simple graph. I do like to keep my data nice and simple. The two lines on here are, the black line is the attendances that we've seen in walk-in attendances, and the red line is attendances for ambulances. Now, we can see that as the lockdown came about around about the 23rd of March, there was that significant reduction in walk-in attendances. But I think it's really important to understand that ambulances did not reduce at the same rate. What we can see is walk-in attendances, now that the lockdown has been easing over the past few weeks, is we're starting to see that significant increase again. And if we move on to the next slide, we can be able to demonstrate this in a more realistic way. So the baseline period I've taken for this is February. The reason why I've taken the February as a baseline position is that February was the last full month of quote-unquote normal data. And so I've just looked at these four metrics. Okay, so we've got attendances total, ambulance attendances, type 1 attendances, and occupied beds. And you'll see that attendances in April dropped to about 50% of their normal levels. Attendances dropped to only 73% of their normal levels. Attendances type 154 occupied beds. But what you can see is that they have been creeping back up again. So although we started to hear this phrase about the new normal, that new normal has gone away quite quickly. And we can see that attendances are already back up to 70% of their normal variation. And actually, we would expect to see that continuing to go up to our normal levels of variation. Next slide, please, Chris. So what we can see, and this kind of really helps with the whole picture around flow, is that our occupied beds has seen a significant reduction. And this is a graph that comes from the UEC daily dashboard. And we can really see that in February, our position from national occupied beds was about 93,000, and that's been gradually coming down. The new national guidance was issued on the 19th of March. And then we can see that there was a prolonged period of stabilisation from around the end of March all the way through to kind of middle part of May. But then we can see that has been gradually going up again. And the interesting thing to notice from this particular period is that we're now starting to see data breaching the upper confidence levels. And that's something that we should certainly be keeping our tabs on. Next slide, please, Chris. So a couple of slides I wanted to pick up on is about the variation. So that was national data, but there is significant variation across the whole country. And I've been working with Cliff Mann, Jim and his other regional clinical advisors around the rest of the country and some of my ECIST colleagues to put together this piece of data. And what this shows is that there has been significant variation in the amount of beds occupied and how that relates to attendances and long length of stay patients. And this all contributes to the flow of patients through the hospitals. And you can see that some organisations have seen significant bed reductions in terms of 45%, upwards of 50% of their occupied beds reducing, but some organisations have not. So some organisations have only seen a 5%, 10% bed reduction. And what we wanted to show was, is there a correlation between something and beds occupied? There's little, if any, correlation between the amount of demand, the attendances coming through the front door. But if we go to the next slide, Chris, we will be able to see that actually the amount of reduction that we've seen through our long length of stay programs and the national discharge cell is that this has highly contributed towards the reduction in overall beds occupied. And this has really helped through the national guidance that came out on the 19th of March. The interesting thing is that both the East and the Midlands regions have seen significant variations for trusts. So one trust, for example, has managed to reduce their long length stay patients by 70%, whereas one organisation has, quote unquote, only been able to reduce it by 47%. The Midlands is really interesting because one trust reduced it by 80%, but another trust has seen no reduction in their long length stay patients at all. And then if we go on to my final slide, Chris. Sorry, this is the ambulance handover program. So what I wanted to kind of show by this is that, and this was talked about by the ambulance providers, is that we have seen that significant reduction. And the two things correlate. And as what Jim was just talking about, was flow through the acute setting helps with the inward demand from ambulance patients and the onward demand back out into community and home provided. And if we go on to my last data slide, what I want to be able to show you is that I've put four different metrics on one particular graph. So the black line is the really interesting one, which has seen a significant reduction of ambulance handovers. And how that has been able to contribute is to flow through the acute sector because our beds occupied, our attendances have come down. But what we can then see is that we're starting to flick back up again, both for our attendances and our beds occupied. And we see that plateau of our ambulance handovers. And the interesting thing and the learning from this is, do we think that is going to continue, or do we think that is going to go back up again? So just conscious of time, I'm happy to take any questions. I've put my email on the last slide. So if anyone wants to get in contact, please let me know. Thanks, Charlotte.
Thanks so much, Chris, and apologies we cut you short. It's fantastic data, and for those working in the acute hospitals and the community, really just an absolute message around how we've got to keep that bed occupancy low to support the flow through for our ambulance services. So really strong message there, and agreed. I feel nervous about what the next few months has got in store for us, but that was fabulous. So thanks, Chris. I'm now just going to very briefly hand over to Jenny Sears-Brown. Jenny's our regional ambulance improvement lead. Many of you will have come into contact with her and has pulled together today's event, and she's just going to do a brief close. I'm not going to come on again after just because of time, so I just want to take this opportunity firstly to thank all of those of you that have joined the call. I think at our peak there was over 180, which is fantastic. What a great way to share learning. And also to our speakers that have obviously taken the time out to run the event and present to us, and some fantastic lessons learned around both staff but also patient journeys. So thank you. Jenny, I will leave you to finish up and to close. Thanks.
Thank you, Charlotte, and thank you everybody who's attended, and especially our speakers. I think you'll agree it's been absolutely invaluable. And my reflections from the webinar, to be fair, is I think it's been absolutely amazing what people have done out there, and in some adverse conditions. So from me, thank you all very much, and I look forward to seeing what the future holds for us from an ambulance perspective, because I think there's some amazing opportunities. So on the back of the Midlands NHS UEC regional team, I'd like to say that the Andover Improvement Programme will be rejuvenated in line with Anthony's national team. So we'll be starting that up again in the not too distant future, and we will be looking at all aspects of ambulance improvement and how we can optimise the digital aspect, the information sharing, and basically conveyance reduction. And very finally, because I'm really mindful that we've gone over, but I think it's been good to go over because it's been invaluable, that we have got an event very similar to this one, planned for the 11th of June, same time, 2 o'clock till 3:30, and we will be looking at the learning that we've gained from PTS, and that's non-emergency patient transport services. And we've invited both NHS and non-NHS providers and commissioners to present on that webinar. So I'm hoping that will be as interesting as this webinar has been. So for me, thank you all so much. Without you all joining and the speakers, it wouldn't have been the success it's been. And take care, stay safe, and I hope to see you all soon. Bye-bye.